Okay, we're recording. Now, it's probably going to do something when I get close to it, so I might have to adjust that again. But here's the point I want to make. I'm going to focus your attention to the hair follicle. First of all, hair has three cycles. Okay, hello. Testing, 1, 2, 3, 4. Okay, I think we said. Testing. Okay, testing, 1, 2, 3, 4. Okay. So the hair follicle has three cycles: anagen, catagen, and telogen. 80% of all the hair is always in a growing phase in your scalp. Okay, so the other 20% are going towards the resting phase. Now, the way it works is usually this. This is the average. We're talking about averages. So 80% will be growing, and it'll grow for a few years. The average is about 7 years. Then you get into another stage called catagen, where it starts to slow down. That lasts for about 2 to 3 weeks, 4 weeks. And then telogen is where the hair actually stops growing in the shaft. Basically, if you pull on it, it will come out very easily. And that lasts for a few months, maybe 3 months, 4 months. Okay? So when they talk about alopecias and they say telogen effluvium, what happens is that something causes the hair to go from anagen, when it's going to telogen, it starts reducing the hair shaft. Okay? So here's the way this works out. I tried to put a color decoder here. The hair is a very complex unit that I'm trying to reduce to simplicity. What I'm trying to do is show you that basically there are 4 layers to the hair without splitting the layers, okay? Starting from, this is called the bulb area right here. So I want you to know this is the hair bulb. This is called the hair matrix. That's what produces the actual shaft. The shaft is colored brown, okay? Around the hair shaft, you have 2 layers. One is called, which is the red in color, is called the inner root sheath, and the one in blue is known as the outer root sheath. Now, we're not going to split that and get very scientific about it. For instance, the inner root sheath has 3 layers in it, but let's just call it the inner root sheath because that's what it is. As the hair reduces the hair shaft, okay, there's 2 things going on at the same time. The hair is growing out, and at the same time, something's happening to the bulb here, so that there's a whole lot of changes here. The hair is normally located in the subcutaneous area, the fat. But as it goes towards a catagen or telogen phase, it actually moves out of the subcutaneous area and goes towards the dermis. And by doing that, it leaves like a scar behind it. But the reason I'm telling you this in short, we'll get into it more specifically when we talk about hair diseases, is because I just want you to see 4 areas. There's a bulb, there's a stem. The stem is located between the erector pylori, okay, which is when you get goosebumps or when your hair stands on end, that's the muscle that pulls the shaft to give you that appearance. And it's all innervated autonomically. You can't control it. Something happens. Like today I was riding my bicycle, a dog ran after me, and I was just startled. And I could just feel my entire body having goosebumps. I wasn't afraid of the dog, but it's an autonomic response. Then just above the hair, where the muscle goes into the hair follicle, there's an area called the isthmus, which is right here. And that is the area that is known just before it reaches the skin. You see the black? The black represents skin. When it penetrates the skin and goes out, okay, the actual opening here is called the ostium. As it hits skin, the black hair, it becomes called the infundibulum. Now Lise, not to pick on you, that's, the reason I did that is because I really love you and I saw that you had a lot of problems with cysts. You called everything a polycyst. So Beth looked at it and said, gee, there's a problem here. So I said, okay, I'm going to get into it with everybody. I'm just trying to help everybody out. So generally speaking, cysts in the scalp are known as polycysts because they're derived from the isthmus. Okay, the isthmus, they come from this area. Okay, this area just starts puckering out and producing cysts. So when you look at it microscopically, you can actually tell the difference because of the way the hair keratinizes. So if I look at a cyst that comes from this derivation, I can tell you by looking out there in a microscope that it's different from the cyst that comes from the other areas. Histologically, it's just totally different. So polycysts come from the isthmus, and they usually occur, I wrote down usually because it's not always this way, they usually occur on the scalp. You can get them basically in the head and neck, but usually just the scalp. So when you're trying to render your clinical diagnosis, just talk about it as being a polycyst if it's in the scalp. Don't call it an epidermoid cyst, because usually epidermoid cysts occur on the skin in general elsewhere, and it usually arises from the infundibulum. And the infundibulum is the area right as it penetrates the skin, and it's actually composed of the same tissue that makes up the epidermis. So what happens is that this skin and this hair attached together create a cyst. And so epidermoid cysts are also known as infundibular cysts, which is the same word. But it's easier to just use epidermal. So if you see something, for instance, on the chest, well, that's okay. I'll explain to you why. Say on the arm, more than likely it's an epidermoid. Or at the back, it's an epidermoid cyst. Okay? Also an infundibular cyst, the same name. Now, it's interesting to note that pilomatrixoma, have you guys seen any of that on pathology reports? Okay, this is a cyst that you'll see commonly, so you should write it down. But where do you commonly see it? You see it in kids, in people who are young. You're really not going to see it too much in older patients, unless it's been kind of like laying dormant. But it happens, but most of the time, if it becomes inflamed, you see someone who's inflamed, you'll notice that it's going to be a pilomatrixoma. It has a very interesting look under a microscope. I always think that if you glue it out, it might be relatively beautiful to look at. It's just a picturesque thing because it's got all sorts of weird looking cells. They have ghost cells and shadow cells and, etc.
And it's benign.
And then this one, it's benign. But pilomatrixomas, which are cysts, just like any of these, because they're made out of cells, can give you cancer. So you could have a pilomatrixoma carcinoma. It's too long a word to say. Pilomatrix, you know what, I don't use the word a lot, so it's hard for me to say. But yes, they become cancerous.
Okay.
They usually do not. It's rare, but they've had cases. Same thing with polycysts. I've never seen it develop into cancer, but epidermoid cysts, okay, have. Now, there's a cyst that you hardly ever see. It's called a steatocytoma. It's usually on the chest, and most of the time when people have it, they have multiple, and it's usually an inherited kind of thing. So usually you see multiple types of, they call it steatocytoma multiplex. So if you read some stuff about cysts, you hear about steatocytoma multiplex. The most common ones that you guys should know about is the epidermoid or infundibular cyst. That's the ones you'll see on the body. The polycysts you'll see almost always on the scalp, with some exceptions, because sometimes it's occur behind the ears and that kind of thing. And the pilomatrixoma, which you usually see in younger people. And if it's retained by an older population, then once when you cut it out, you know it's a pilomatrixoma. The stuff, if you hit the cyst, the stuff that comes out of it is not cheesy. it's more like, it's a little brittle, it's more like cement. It's more calcified, because they more often can become calcified, but it's totally different, okay? These usually do not stink. I've never seen a stinking polycyst because they usually do not get infected. These usually have an odor to them that's rancid, and my girls don't like to train them. But we're going to talk about cysts right now because of some other areas that you guys are under misconception. These do not have any rancid odor, and neither do these. Usually the ones that get infected are the epidermoid cysts, and they have a very rancid, disgusting odor. Yeah.
When you have like a couple of highlighter-looking cysts, like how would you differentiate that from folliculitis versus like on the scalp?
Oh, you don't have to distinguish it because you'll see an obvious cyst versus folliculitis.
Well, I saw one of the patients last week who had like a couple of these cyst-looking nodules like all over his head. One of them was really
Well,
big.
okay, you just said the word cyst-looking nodules. Well,
Yeah,
they're cysts and they're inflamed, they're not nodules, okay? Folliculitis is a little erythema around the hair follicle. That's all it is. That's
it wouldn't look like sebaceous
pustule, a
hyperplasia.
little tiny pustule, huh?
Oh, okay.
Yeah,
Not
it's
like
a little tiny
sebaceous.
like pustule around the hair.
Okay.
It's not like a cyst. A cyst is totally different. It's kind of subcutaneous or,
Yeah, but it was
subepidermal.
just that particular person I was like kind of iffy
Yeah, you're
about,
wondering
is it
about
a cyst or
If
is it-
it's one in perifollicular erythema or pustule,
Mhm.
it's usually a cyst, okay?
Is it
Now-
was just bumpy all over it.
Oh, bumpy, now that one, you might be talking about acne culodalis nuca. Have we've gone over that.
Mhm.
And if we didn't, please write it down, go ahead, make a note of it. Because that's common. Acne, ACNE, keloidalis, from the word keloid, and nucae, being on the neck. Usually these occur, in dark-skinned people with corkscrew hair, when the hair's got too short, and they irritate the skin and actually form tiny little keloids. And the way you treat it is you numb the area, and I kind of try to kill two birds with one stone. I take a little Novocaine and I add some Canadag, and while I'm numbing them, I'm actually already injecting the keloids. The little tiny perifollicular keloids. Some can get gross, so gross that they look like huge, humongous keloids. Okay, but generally speaking, they're tiny little keloids.
It was more like sebaceous hyperplasia kind of look, like the way.
Yeah, but that doesn't really occur back there. Why don't you start taking pictures, and when I see you guys, just ask me questions, or email them to me, or to Patty. Don't be shy, You guys are in the learning phase right now.
And then
And
there was another
every
one.
picture you ask us about, we don't consider you guys being stupid, otherwise you wouldn't be here, okay?
Mhm.
But the bottom line is, you need the experience.
And there was a referral patient who came to me last week, had a cyst on his eyelid, which he said 10 years ago when he saw an ophthalmologist, he said it was, you have rosacea. Well, it just did not make sense to me, and I was like.
No, that's not rosacea, right?
Was that?
Yeah, you're right, it's not
So then it
rosacea.
was like, literally, it was on his eyelids, I didn't want to touch it.
Now,
so-
the cysts that are right on the eyelids, they're a different kind of cysts. They
It
actually
was
grow
right
the
there
muscle.
on-
Yeah.
it wasn't
If they're
even
right
a
on
margin,
the,
like
now,
not
if
a
they're
side.
right on the eyelid, I don't mess with them because they
Yeah,
can be
yeah.
abscesses, they can involve a little bit of it could be tiny cysts, but they're too close to the muscle, and I usually send it to an ophthalmologist. If they're on the eyebrow area, in this location, even below the hairy eyebrow, then I can remove them, that's not an issue. But I don't like messing with the lids because they're just sensitive. I used to do blepharoplasties.
Mhm.
That was different, but the cysts, I just send them out to an ophthalmologist. Yeah. What's up?
The
Epidermoid?
Yeah, now you
Epidermoid.
said that they can become cancerous?
Usually not.
Yeah,
I've never seen an
Which
epidermoid
ones did you
cyst.
say that could?
Well, most of the cancers that are derived from hair follicles are sebaceous carcinomas, and they're not related to cysts.
Okay.
A true cyst doesn't become cancerous. A pilomatrix carcinoma, I think that's what it's called, pilomatrix carcinoma, happen, but they're rare, extremely rare.
So you just
Dfsp do not, usually do not, but you see, in dermatology, we see all sorts of tumors.
Yeah.
And you know, there's a lot of people think that they're derived from the hair follicle too, so. But look, let me tell you some things, okay? And this is something you better keep in mind, so you don't get in trouble. That's what I'm trying to do, keep you out of trouble. I had a patient who, Dr. Ma referred to me, who was walking around with what everybody called the cyst on her anterior shin for years. She had seen a bunch of dermatologists, not in our practice. And Dr. Ma, you know, I harp, if you're in doubt, you gotta do a biopsy. Well, she decided to do a biopsy. Turns out that it was a adenocarcinoma, okay? This woman followed me around for a whole week, from one Mohs lab to the other Mohs lab. When I was done with her, basically about a quarter of her whole leg, I'm talking about an area this big, okay, and this wide, down to muscle, I had it removed. I had to send it to Dr. Nagy. She's had to have all sorts of multiple procedures done, you know. So people always assume that you're dealing with a cyst, you know, and I don't assume anything until I check it out, you know. So if a patient has a growth there, I just remove it. I've had patients that have come to me with skin-colored papules, okay? I would shave them off and turn out to be a Merkel cell carcinoma. Had I not done that, I would have written their obituary, basically. Because it kills people a lot quicker than melanomas. Okay, it's a small cell carcinoma like the old cell carcinoma, but they call it Merkel because it comes from the Merkel cell. So if something grows that hasn't been there, it doesn't belong there. That's my whole philosophy. Okay, I don't care, you know, whether the insurance company likes it or not, it's just too bad, okay? I'm here to help people out, okay, and prevent any catastrophes. And you know what? And so they'll say, well, it could be 1 out of 500. All right, so I don't want to be one of that 500, let's go. Send Joe Schmo back, you know? So statistically, it's less likely it is, but we see all sorts of crap all the time.
So if it's something new to the patient, like I've never noticed this before and all of a sudden it popped up and...
Yeah, then you check it out. You know, if it's benign, great. You do your biopsy, going into an excision, and you know, everybody's happy.
Mm-hmm.
Now, let me just take you past this. I want you guys to write this down. I want you to go home and memorize this, okay? So when you do your notes, you know, you come to the right conclusion. So what do I want to talk about now is this. I'm going to ask you questions. Don't feel embarrassed. I want you to answer me. Ron, you have a cyst, for instance, that's inflamed. How do you treat it?
It's cyst, inflamed
It's
cyst.
inflamed
It's
cyst.
probably treated with antibiotic to start off with. You don't excise it if it's inflamed.
Okay. Say that, excise if it's inflamed?
No, you don't.
You can't excise it, okay. How long would you keep someone on an antibiotic? 14 days. What do you think, Lisa?
I would say 4 weeks.
I'm going on your notes, that's why I'm doing this. What do you think?
7 to 14 days?
Yeah? Well, what if I tell you 2 or 3 months?
It's too long.
Okay? Now, that's the way it goes. Listen, what you're going to do is you're going to put those patients on, you're going to give them a month's prescription, and then you're going to check them every month. Okay? And when that cyst stops draining, it's not erythematous, it's not tender, and it's kind of shrunk down. Okay? Then you can take them off it. In general speaking, you can take a few weeks off here or there, okay? Generally speaking, most of the cysts that I see, that I take care of, I usually keep the people on for about 2 or 3 months.
Oh.
Okay, why? Because one, they're infected, and two is, there's some antibiotics that have been shown to have an anti-inflammatory effect, okay? Not only by decreasing the bacterial load, but also by having almost like an aspirin effect, not the aspirin, like an NSAID effect. There, some of that. But anyways, generally speaking, my experience has been you keep them on for 2 or 3 months, and we do not do surgery on it until there's no erythema, no tenderness, no discharge. Otherwise, we got to take a copious amount of tissue just to get around the inflammation. Okay, usually when it heals up, what happens is that we can identify the sac, you know? And if we could identify the site, then we're doing okay. I don't want to lose sight of the camera, so I'm going to put this down. But I want to show you something. And this is what I do with patients. Hold on. What I like to do with patients is draw on the paper on the table and explain to them what's going on in their body. So when they leave, if they understand what it is that you just explained, they really appreciate that, you know? They really appreciate that. I know when I see a doctor, I like to know everything that goes on because I don't want to be confused, you know? I want to know what I have and how long it's going to take to get rid of it, etc. Okay, but I want to show you an example of what I do, and I'd like you to get into this habit, to create habits. So let's imagine that, Kathy, you're my patient, okay? And you say to me, okay, you come in, I diagnose the jab and inflamed cyst. And you say, you're not going to do surgery. And maybe the patient has waited an hour to see it. So now they're upset because they've waited until Tuesday, they figure you're going to cure them. But you're going to tell me you're not going to do that. Instead, you're going to take out a pen and say, you know why I can't do it? I want to explain it to you. The word I want to explain to you makes a big difference. You can take your pen and you're going to draw a circle. And you say, see, man, this is a cyst. And what happens in a cyst is that you've heard a lot of doctors say, you know, you have a cyst, don't worry about it, leave it alone. How many people have seen primary doctors say that? Patients come to the office, we do a body exam, looking for, and we see a cyst. And they say, oh yeah, I showed it to my doctor, says, yeah, don't worry about it. Well, that's not the right way of doing it. What happens over time, is that all these cysts have material in there. It's called keratin, okay? This keratin continues to build up. It grows. Unless you're dead, everything grows unless you're dead, you know? You gotta cut your toenails, your fingernails, your hair. What doesn't grow? So this thing is gonna grow. And this is what you have to explain to the patients. Their lipomas are gonna grow. So they say, well, it doesn't bother me. So you know what I say to them? It doesn't bother you now, but when it bothers you and you come to see me, I'm not gonna be able to remove it because for 3 months you're going to be on an antibiotic. And they say, oh, I see. It's like if you have a tooth decay, oh, doc, don't worry about it, my cavity doesn't bother me. Okay? Well, wait, wait till you need a root canal, then we'll take care of it. Okay? So in the same sense, you have to explain to the patients why. Why are you talking to them about it? So what happens is that as it expands, what happens is that now you get a tear. You get a tear in the capsule, okay? Now this capsule could be what I call, it's an extension of the epidermis, whether it's from the hair follicle or an epidermoid cyst. And this stuff, okay, and you show it to them, big stuff, and especially, Becky, like if you're in new offices, you got all the time in the world. And when you impress somebody, they'll tell people that you're great. Okay? But anyways, this stuff just leaks right out. Now what happens when you've got a foreign object in a place that was contained? The body sees it, says, hey, I don't like you, I'm going to react to it, I'm going to go treat it as if it's a foreign body. So it sets an inflammatory response to it with white blood cells. They form giant white blood cells, okay? Giant cells, etc., etc. Then what happens, in addition, okay, you get an infestation of bacteria. Sometimes the bacteria is already sitting in the hair follicle along the walls of the hair follicle anyways. So it gets into that, okay? Now you got a ruptured follicle, which is infected, and you can't do anything about it. You got to wait and see it. So don't send people to, if you're going to do the surgery, wonderful, do it when it's very quiet. If it's active, don't send it to us, because I'm going to piss them off. I'm going to tell the guy to go back home and send the antibiotic. They'll tolerate antibiotics for 2 or 3 months. It's not an issue. Tell it to take it with food so it doesn't irritate the GI tract. Okay? So that's the thing about infected cysts. Okay, put them on antibiotics quite a while, they come down, see them back every month, because maybe they'll be totally quiet after a month.
Can you do an IND on those?
You can to relieve the pressure if you'd like to. So if you do that, just puncture it here somewhere, and then press the stuff out. You don't have to pack it, okay? Packing is something that people do in the emergency rooms, okay? You don't have to pack cysts, okay? If you drain it, great, but most of them are so tender that you want to stay away from them. You know, I mean, those poor people, you know, just beginning some antibiotics.
If they say that it's really tender and if you can help me, you know.
Well, you know what, you're gonna deal with different people. People come in different packages. Some are gonna complain about it being too painful, some say, I'm gonna have to give you an injection. I would just tab the damn thing and push it. You have to numb it and discharge it, and usually code we use for that is drainage of a complex cyst, 10061, okay? Yeah, so that definitely helps, if you can. A lot of times it just starts out and you can't drain it. Oh, science, when can you drain a cyst? You know, every cyst, can you see me from the camera? Because I want to use this for teaching purposes. Yeah, just look through the please. When the cyst is hard,
You want me to? Okay.
when the cyst is hard, you can't drain it because it's very, very inflamed, okay? It's like trying to drain a brick. When it gets soft, maybe, you know, then you can drain it. So it depends on when the patient comes in, etc. You got to take a few factors into consideration. You know?
What if it's just a scar tissue, like after like so many times this is just being there and
Oh, good. That's a good
then it
question.
gets into a
Let me
scar?
tell you what I see a lot of times. People come in and say to you, I've had this thing go up and down, meaning they're painful, then it goes away, then it comes, but when it goes away, I don't feel anything, they say. But then it comes back a year later, and the same thing happens, and it's painful, and then it goes away again. So, the bottom line is, if you actually excise it, which I think you should, what you see underneath the skin here, is a little tiny cyst. It sits there right like that in the dermis, okay? It doesn't do anything, it just sits there, you know? So, I would excise that, okay? Because there's something there. Things don't enlarge and become painful if there's nothing there. That just doesn't happen, you know? So that's a still on the cyst. Now I'm going to go to some papers. I want to see if there's anything else I need to bring up. Oh, yes, this is very important. Ron, go downstairs and turn and close the door, please. I'm going to put the air on. It's going to go along here.
And one more thing, if people have like multiple cysts, you can take excisions.
If you have what? Why not? What's the problem with that?
But like how many excisions you have?
10, 20, doesn't matter. What's the problem? Is there an issue with that?
I had a lady who came in with like a couple of nodules all around her neck. And then there was one that was inflamed, which I tried doing an IND, but then I couldn't get anything out. And these, I didn't know if they were cysts versus if they were anything else. So I did like punch biopsies on each
Okay,
of them.
well, you see, remember that Dfsp multiplex? Sometimes they present like that. Sometimes you've got, now in patients which have kind of hereditary steatocystoma, you can't really do excisions on all these cysts. You really can't because there's so many. There's like maybe 30 of them. And at a time they're very small. But we get patients coming in with cysts on the earlobe. Okay, that bother them. They become inflamed and they go away and they come back. We remove those.
She said she never had anything coming out, but they were just there and she wanted to know what they were.
Okay, so you did the right thing. Yeah, you did the right
So I
thing
did
by
like
doing
two
a
punch
biopsy.
biopsies to make
Yeah.
sure.
That's good. I think you did the right thing. Very good. Okay, Lisa, can you turn the camera back to your line just a little bit? Okay, I'll tell you what I want to do is just juxtapose this for you. What I want to do is I want to ask you guys another question. Now you pretty much understand cysts and how to treat them, right? Okay. Next question is, okay, And I'm going to go around the room again. Maybe I'll start this. You have a patient that comes in with an allergic contact dermatitis, okay? That needs prednisone because it's all over the body. And she's very, uncomfortable. So, Lisa, how long, she needs to be on prednisone, how long would you keep the average person with a severe allergic contact dermatitis on prednisone for?
To do a taper over a couple days, about 2 weeks.
2 weeks, okay. Because one of your notes, you had a patient on for like almost 4 weeks, I think. We'd have to go over it 555 and for 19 days, okay? Which, I think that's okay, but I just want to go back into it, okay? Just so that you don't mess up.
I got that off of one of the other providers, that's how they.
Okay, let me tell
their
you,
taper.
remember some of the providers that have been doing this for a while now have either developed their own sense or whatever, or I've never taught them, okay? Especially, for instance, Dr. Trivedi came in and supposedly came with knowledge from California, so did Dr. Dixon. So they came in with some bad habits. But you know what, you can't mess with bad habits because they don't like that, you know?
Can I tell you the
Yes.
taper that I have, and then you can pick it apart? and
Yeah, it's
tell me
right in
why?
there, it's in that sheet, that's your whole package.
That's on here.
Yeah.
All right, I do start adults anywhere between 60 to 80 milligrams a day, and then taper over 2 to 4 weeks.
Over,
I have 2 to 4 weeks.
see, that's wrong, that's the problem. Okay, so let me explain to you, okay? First, let's just kind of get a sense of feeling. When you meet a person, you get an impression of them, right? You meet anybody in the street, say, yeah, this kind of guy, yeah, I'll talk to him, I forget about it. Oh, no, he's like the quietest. I mean, you got to get a sense of that for people you treat, patients. So in your own mind, I want you to kind of think about whether this allergic contact is mild. Just started out, it's got a couple of blisters, nothing major, but you can tell that the creams are probably just not going to do the trick, or they're severe, okay? Okay, so we're talking about allergic contact dermatitis, okay? If they're severe, they're going to have a lot of blisters, they're going to be weeping all over the place, they're going to be extremely uncomfortable, etc., okay? If they're mild, it's just much reduced in that essence. So if they're mild, please, you can probably get away with 12 to 14 days, okay, of steroids, and you can do, depending on the size of, now Dr. Tager puts people on prednisone depending on their weight. I kind of just eyeball people with severity, because they're not going to be on it for long. It's important to please indicate in your chart when you put someone on prednisone, so you don't mess up. You got to find out if they've got diabetes mellitus. Imagine not asking, the patient doesn't tell you, you put them prednisone, you throw them into a hypoglycemic coma. Just imagine that. And they don't recover. So make sure you ask if they have diabetes, because we talked about all the side effects of prednisone in the past. 1. 2 is, if they have hypertension, okay, and ask them if they get it monitored. It's not a major issue, but if they're borderline, like really bad hypertensives, you don't want them to, pop a cork in their brain, okay? So these are important questions to ask people, okay? If they're pregnant, and then, so I can think, can you think of something else?
Ulcers, history of ulcers.
Oh, yeah. If they have
Or
ulcers, it
glaucoma.
can definitely aggravate it.
Glaucoma.
Yeah. But these are less, you see, we're talking about, these are good questions if you're going to treat people for post-Mefico, which we're going to talk about today, okay? But if you're treating them for something for 2 weeks, I'm not totally worried about that unless they tell you that they're ophthalmologists, if they have eye problems and ophthalmologists are worried about acute ankle glaucoma, they're going to treat it for it. So that would be cool. Ulcers, they're usually not going to blow a hole through their stomach because you're going to put them on Tagonets anyways. At the most it's going to do is irritate them. But you don't want them to be diabetic, and you want to watch this, because these things are potentially lethal, all these arrows that I'm pointing to. So those are the major things that you need to do, okay? Now go back to using prednisone, okay?
Okay.
If it's a mild case of acute contact dermatitis, 12 to 14 days usually does the trick. And if it doesn't, and you didn't misdiagnose them, you could put them back on it. So that's important, okay? If you're dealing with someone who's severe, you might, and usually the dose I start people, unless they're very large people, okay? I usually start these people on 60 milligrams. And usually I do a taper like every 4 days. So you see how I get the 12 out of it? Every 4 days, I get a taper out of it. Now, if they're very severe, what I'll do is, I'll start on a higher dose, probably about 80 milligrams. That's after I've given them, I've done my history, my good history here, and I've given them Tagamet. And if I plan to keep them on longer, in your mind you would know that you might want to add some calcium. I mean, I would talk about adding calcium because of the side effects of that. So I start on 80 milligrams of prednisone for a couple of days, 2-3 days, then I go to 60, 40, just like I would do with a mild situation. And maybe on a patient like that, I'll keep them on for between 2 to 3 weeks. The other ones, basically, between 1 to 2 weeks, more towards 2, and I go up more towards like 2 to 3 weeks, you know? So, that's why we teach medicine, but then it's an art after you taught it. All I'm trying to tell you is that you don't have to put everybody on on 4-week regimen on high doses. You just kind of tweak that. Okay, and that's kind of what I want to teach you, how to practice good art. Because I'm teaching the science, that's the art of using the science.
Can you do this with bad flare-ups of eczema?
No, listen, we talked about using prednisone with that. It's the very last choice. You're going to have people who are totally addicted. They've seen other dermatologists and they're getting shots of cortisone every month, every 2 months. I'm going to ask you to do that. Try to put them on strong topical steroids. But I want you to put a note right now because I told you the provider is no longer with us. Got sued for having used a triamcinolone, which is like a class, it's no big deal, it's like, I don't know, class 4 or something, for having left like a 12-year-old girl on it for months. And she developed stria all over her body. He's going to lose that. There's no way he's going to defend that. He kept giving it back, giving it to her, giving it to her. There's other ways of clearing eczema. There's light treatments, you know. And there's other things that I'm sure you didn't do right. So I prefer that you did not use prednisone. Now, if you absolutely have to, either from a guy who's already addicted to it, or someone's going to abuse it, have them sign a consent form, with a medication consent form, that basically covers you because you've told him about the probable side effects and he still wants it. You know, you still have your notes on the long list of side effects. So just sign a consent form. Okay? Was there any other questions on this?
And you don't want us to do IM ever on anything? IM.
Oh, actually, no, don't do IM. Why? Because you haven't seen patients who come in like I have complaining of atrophy. Once you give them a shot, you can't take it back. If you give them a pill, you can tell it to stop. Once you commit yourself to a shot and they have side effects, you're screwed. You can't take it away. So there's a psychological dependency also on injections. That's why people do that. They shoot other people because they figure they'll come back for another shot. We don't need that. We've got over 3 million patients. You know, they can come back because they like us and they think we practice good medicine.
There was a patient who we saw like really bad flare-up of eczema with super infections, like fungal super infections because she had the intravenous Dariers also. and she had been getting the shots from some other dermatologist.
The people, a lot of the doctors in North Jersey do that. They do that for a lot of different reasons, which I'm not gonna get into now.
No, but that's what I'm clarifying, because the patient was.
You know what, if you have to do that, do it, and then start talking to her about how you're going to change the way she's been treated, because it's not good for her.
No,
So-
if you're not gonna, if you don't want us to do it, I'm not gonna do it.
Yeah,
I'm just
but you know
asking
what,
if
the problem is, sometimes you don't have a choice, you know, because prednisone gets people very, much better quick, but they also have the flare-up phenomena when they're off it. So if she's gonna stick with you, and you can give her a shot, just start changing the way you, the patient's being treated for her benefit. Because you need to explain to her that that's not the right way of going about it. You know? I mean, you know, people practice with different level of ethics and concern, you know? And the concern is that I think they don't think there's any side effects to any of this stuff. You know, and I try to practice according to the science of it in understanding these side effects that patients have with everything I would give them. You know, I think that's very important. And I think people recognize that when I was practicing patients. You know, I did my best not to hurt them.
Now, when you speak about contact dermatitis, a very simple form of something like poison ivy, is on my 5th day, so I don't know.
That's okay. There's no stupid question.
Okay, you've got poison ivy, and I used to get that as a youngster, and boy, it was devastating. But now, some people use Midroll dose packs, but somehow it doesn't cover. So you start with prednisone to taper over 10 days to 2 weeks. That's okay. It goes away. But you're talking about a contact dermatitis that maybe someone had for a long time and you can't find the etiology. So you treat with prednisone or steroids.
No, we're not talking about that at all, Mike. We're talking about someone comes in from the woods and said, damn, look at me. I cover with blisters.
Okay, well, what happens when you're treated with prednisone for a fair amount of time and you're still, or it does go away, it might come back, or never totally go away? Are there any alternatives?
No, once in a while that's what happens. If you treat it for a little too less than what it takes, you might have to get another treatment again. You just have to make sure you're treating the right diagnosis. That's all, you know. If that happens, sometimes it does happen. Just like impetigo, you treat a patient with impetigo for 2 weeks, okay? The patient comes back a month later and says, guess what? I've got it again. All right, I'm going to give you more antibiotics. If he does that and comes back again and tells me, and I'm sure of my diagnosis, you know, I've done my cultures, I've done maybe whatever, but I'm fairly sure that I'm going to try to put him into a category where he might be a carrier. So what I'll do is culture his nostril, his throat, perianal area, everywhere, okay, just to make sure he's not a carrier. Some conditions that are, I call them like benign conditions, sometimes they do recur, you know, and you're forced to do that. Yeah. So, but we're talking about just simple contact. Sometimes it's just an erythematous patch, a couple of packages, just get some topical steroids. Take a bed for a week or two and goodbye, adios. Take some Benadryl, some Natarax, but then there are people coming with blisters with a few streaks of blisters, and you just know it's going to keep spreading. So that you treat as a mild guy. And you got a guy who comes in and says, I've been in the woods for 2 weeks hunting bear. And he comes in and he's got blisters on his private areas, on his face, on his arms. You know that a 2-week dose is not going to do the trick. So you keep doing a 3-week dose and you're pre-planning your tapering that way. And you see it more often, so maybe you're tapering him a lot quicker than it needs to be. You know, listen, the best way of practicing medicine is to see your patient die. Not to give them the medication and say, all right, you know, or you could give them medication and say, look, if you're not getting better after 4 or 5 days, you need to come back to let me look at you. You know, communication with patients is like the most important thing we do. You know? so just, and this is something we see constantly. All right? All right. Okay. Now, I'm going to put the blinds down a little bit. Did I say I would talk about something last time that I basically forgot? You guys remember?
When it bears blood,
Vasculitis, I talked about it.
talk about it some. He started it, but I don't think he was finished it really.
Oh, yeah, 'cause,